you need me to go through, so I'll be clicking the slides, including during when you discuss the CEs and all that?
Um,
Okay,
yeah, you can scroll through those things, except you do want to sit and explain to everybody about any conflicts of interest on that slide in particular.
yeah. So what do I do? Do I click, are we there?
Right now is the awkward silence that we have while everybody is trickling in. And then in about 30, 45 seconds, I'll start your introduction.
Okay. I am watching that number increase.
Don't pay attention to that.
It's just the number. I think you're just making that up, so I'll feel good.
Okay, welcome everyone to the University of New Mexico Law and Mental Health series, weekly discussions of practice and science featuring experts in behavioral health and the law. This is a series run by the University of New Mexico's Division of Forensic Behavioral Sciences in our Department of Psychiatry and Behavioral Sciences, along with support of the New Mexico Behavioral Health Services Division. I'm Anthony Perillo, the Forensic Psychology Training Director here at the University of New Mexico. For our talk today, if you have any questions for our presenter, make sure you enter those in the Q&A box. You can enter those anytime you feel comfortable, but do know that we hold questions until the end, and oftentimes it's not possible for us to get through all of them. In terms of continuing education credits, if you are pursuing continuing medical education credits, there is a sign-in sheet that is posted in the chat box now that you can use to process those credits. If you are pursuing APA continuing education credits, you will also keep your eye on the chat box for a link to a survey that you can complete. But that link will not be posted in the chat box or be available until near the end of the conversation and near at the end of the webinar. So keep your eye as we get drawn to a close. Make sure you bookmark, copy, have access to that link before the webinar closes. And once you complete the survey, make sure you save a version of the certificate after you complete the survey. We don't have those certificates after the fact. If you missed our most recent talk in the series, Dr. David Feldman's discussion of forensic evaluation with deaf individuals is now available on our YouTube channel. The recording for this week's talk should also be available on our YouTube channel sometime later this week, and a version of the PowerPoint slides for those that have registered and attend the series will be available later this week as well. As a heads up, we will be taking the next 2 weeks off in the Law and Mental Health series as UNM and the Forensic Division travels to and from the American Psychology Law Society in Reno. Make sure you say hello to us if you see us. There will be many of us from the division there. And then we will return with the Law and Mental Health series in 3 weeks on March 24th. We have Dr. James Fairfax Colombo, who will be discussing the sequential intercept model. But circling back to this week, I'm excited to introduce you to today's speaker who will be overviewing evaluation of risk of sexual violence. Today we have with us UNM's own Dr. Jorge Varela. Dr. Jorge Varela joined us at UNM as a professor of psychiatry and behavioral sciences in June 2025. In addition to his clinical work through our Division of Forensic Behavioral Sciences, he serves as Vice Chair for Education and Director of Training for the Doctoral Internship in Clinical Psychology housed in our department. His current clinical responsibilities include conducting forensic assessments both in English and in Spanish, and psychological screening of candidates for positions as law enforcement officers and firefighters. Dr. Varela completed his undergraduate studies at Florida International University and his Ph.D. in clinical psychology at the University of Alabama. He served on active duty as a psychologist for the United States Air Force for 9 years, including his internship at Wilford Hall, United States Air Force Medical Center. As an Air Force psychologist, he served tours as a staff psychologist at Maxwell Air Force Base, as a staff psychologist and internship faculty member at Wilford Hall, USAF Medical Center, and as mental health flight commander at Kirtland Air Force Base here in New Mexico. Prior to his appointment to the School of Medicine here last year, Dr. Varela served as a faculty member at Sam Houston State University. While at Sam Houston State, his scholarship examined questions related to sexual violence risk assessment, forensic assessment, and the intersection of forensic assessment and multicultural psychology. He mentored several doctoral students in his forensic research, including those not in his program, like yours truly, where I met Jorge about 15 years ago at this point. In addition to his teaching, research, and service opportunities, he served as director of clinical training for the doctoral program and the chair of the psychology department at Sam Houston State University. So, Dr. Varela, Jorge, on behalf of your new home of University of New Mexico, thank you so much for joining the series, and we're thankful for you sharing your longstanding expertise with us today. I will go ahead and toss it over to you.
Thank you, Anthony, for that kind, really generous introduction. It's an honor to be here. When I think of all the wonderful speakers you've had here during your time and even before, it is something to be considered for this. So thank you, and thanks to everyone for taking the time to being here. There's a couple of things of business that I have to take care of before we get into the substantive presentation. The first is my disclosure that the presenter, me, does not have any financial arrangement related to the content of this activity. Okay. And I also want to be absolutely clear that the views expressed in this presentation are those of the speaker, me, and do not necessarily represent the views, policies, and positions of the University of New Mexico. This is based on my experience and my review of literature and is not the official position in any capacity of UNM. Okay, so kind of by way of overview, and I want to first talk some about sexual violence as a whole, briefly talk about the scope of this matter that we're talking about, and then I want to quickly review the DSM-5 DSM-5-TR paraphilic disorders, because diagnosis is often an important component in this kind of work within the justice system. Then talk about sexual violence risk factors, and then risk assessment models and methods. Okay, so talking about sexual violence. Okay, so these are data that were published in 2024 by the Bureau of Justice Statistics, and here we see over the course of these 5 years represented in these results, the rate per 1,000 people of rape or sexual assault. So you can see here that the number was at 1.7 in 2019. It dropped during the years of the pandemic, but it's kind of back to where we were before. And we can look at this study by Professor Finkelhor and colleagues from 2024, looking at child sexual abuse, and you can see here this is looking at what they refer to as generic child sexual abuse, online child sexual abuse, and then a composite measure of both. This is over 2,600 18 to 20-year-olds surveyed about childhood sexual abuse and image sharing, non-consensual image sharing, forced sharing of images. That's referring to the online sexual abuse as in extortion, soliciting sexual talk, questions, requests for sexual acts. That's what's going on there with that online sexual abuse. You can see a lot of people have been subjected to this and had to survive this. So what do we know about sexual violence? And really the emphasis has been on reoffending, looking at an often cited meta-analysis presented by Hansen and Morton Bergen in 2009. Those of us that work in this area are probably familiar with this. They looked at 118 studies, and they see that the sexual recidivism rate overall was 11.5%, based on almost 29,000 participants in the primary research. Sexual or violent recidivism, as we expand the category a little bit, we look at almost 20%, and then any recidivism is at 33%. Now, it's important to take into account that these recidivism rates and any estimate of recidivism is very context dependent. That is, jurisdictions vary with how they police people who have been convicted of sexual offenses, how they monitor, how they supervise people in the community. how long they do that, if people have been incarcerated and then released from criminal justice custody. So it's important to consider that as we consider these estimates of recidivism. Okay, so with that as a backdrop, let's start talking in more detail about things that relate to the justice system. First, let's talk about the paraphilic disorders overall. There are 8 disorders. The disorders themselves, what was selected for the DSM, represents what they thought of as relatively common, at least among these kinds of behaviors. These tend to be things that are criminal or can be criminalized, and dozens of others could have been identified. Those of us who've been around this know that there's various, blank philias that could be listed, but the writers of the DSM chose these 8. This is a definition of a paraphilia, and intense and persistent sexual interest other than sexual interest in genital stimulation or preparatory fondling with phenotypically normal, physically mature, consenting human partners. Now, one of the difficulties in thinking about this definition and thinking about the paraphilic disorders as a whole is that things like sexual desire, intensity of sexual desire, that changes over the lifespan. So, for example, someone who is much older may have diminishing sexual interest in sexual activity. It's not always the case that someone has some exclusive sexual interest. So some authors, and I see the value in this, have considered maybe it's better to think of preferential sexual interest rather than as an exclusive sexual interest. So let me kind of just, for shared understanding, diagram out here the DSM-5 paraphilic disorders divided into anomalous activity or anomalous target. The activity disorders are divided into courtship disorders, which kind of a deviation from or distortion of courtship behaviors like voyeurism, exhibitionistic and frauderistic disorders, and the algolognic disorders referring to pain, experiencing or inducing pain. And then among the target disorders has to do with distortions of what the individual wants, what is the target of their sexual interest. Pedophilic disorder, of course, referring to prepubescent children. Fetishistic and transvestic disorders referring to other things. So the diagnosis of paraphilic disorder involves, one, the qualitative nature, that's the first criterion, the action or the target, and then B, the negative consequences, distress, impairment, or harm, and both must exhibit both for 6 months for diagnosis. That doesn't mean that someone can have a subthreshold paraphilic sexual interest, but rather this is how we make a diagnosis. And by just way of example, here is the DSM-5 criteria for pedophilic disorder. You see 6 months of recurring intense sexually arousing fantasies, urges, or behaviors involving a prepubescent child, and then that you've acted on these urges and fantasies, causing distress or interpersonal difficulties. Pedophilic disorder has some additional age considerations, at least 16, 5 years older than the child or children in criterion A. So, for example, someone who is 14 and has sex with a 13-year-old or a 12-year-old, let's say 12-year-old, because let's talk about prepubescent, that would not necessarily represent pedophilic disorder. And there's some specifiers that are important clinically and actually, to some extent, even risk-wise, exclusive or non-exclusive, attraction to male or females or both, or limited to incest or not. Interesting about pedophilic disorder is that while most of in fact, I think maybe all the other paraphilic disorder diagnoses in the DSM have specifiers of in full remission or in a controlled requirement environment. Pedophilic disorder does not. I am yet to read a good explanation of why that is the case. If someone has it, please put it in the chat, because I think a lot of us who haven't seen that would be interested to know Finally, just a little bit more about paraphilic disorders. Normally, if I'm thinking about a disorder and talking about a specific disorder or diagnosis, I think it would be important to talk about prevalence and incidence. But these estimates are really absent. Strong, reliable estimates. I mean, definitions have changed over time. It varies with clinical or non-clinical samples. And of course, these are clandestine behaviors, right? If we're doing, broad survey, epidemiologic survey research, it's not like you're going to walk up to somebody and say, "Hey, I'd like you to participate in my research. Tell me about your sexual interest in children." People aren't going to talk about it. We do think that paraphilic interests exceed, there's more people with paraphilic interests than there are with the disorders. We think of men having a higher prevalence or an incidence than women. Again, returning to why I'm even talking about this, diagnosis is integral to evaluation in psycholegal context. And an example that I'd like to share and use, which is pertinent to my practice over many, about 12 years, has been sexually violent person evaluations in Texas. So diagnosis becomes important there. Okay, so I want to talk some about the assessment of sexual deviance and kind of explain why that's important. So this is again, often cited meta-analysis by Hansen and Morton-Borgon in 2005. I know it's 20 years old. It's still, I think, relevant here. And just to point out that when we think of risk factors for offender recidivism, you see that sexual deviance has a pretty decent effect size when we're thinking about trying to estimate the likelihood of this behavior. And sexual deviance in this context is defined poor sexual self-regulation, like managing impulses, using sex to regulate your affect, high-risk sexual behavior, atypical interests, arousal to children or violence, paraphilic interest, and intensity. The other stronger predictor that's often brought up in the context of these findings is antisocial orientation, referring to juvenile delinquency, criminality, and antisocial traits. And it's important, an important point here that sexual deviance, and antisocial orientation are the best predictors of sexual recidivism, right? And that makes sense if you think about it conceptually. If offender has into deviant sexual stuff and is okay with breaking the law, we might see that. So how do we assess for sexual deviance? I mean, of course, there is the clinical interview that we would engage in, but there are some specific techniques for doing that, although they may be difficult to use in criminal justice context. For example, one is penile plethysmography. Often this is treated as the gold standard for measurement of sexual interest. And there's variations in how PPG, penile plethysmography, is administered with visual stimuli, auditory stimuli, and the idea is that we measure directly some indicator of sexual arousal, whether it's in the case of male volume changes in erection or penile circumference. The use has been challenged. Let's not pretend that everything here is perfect, but we do have some data, meta-analytic data from 2019 that really shows us that when we compare people to sexual offenders against children, looking at different age groups of the stimulus, pedophilia, hebephilia, or teleophilia, you kind of see that these effect sizes are pretty good. So it does help, certainly. If you have access to PPG data, whether it's data that's collected through your own work or through maybe a custody setting, like a prison treatment program or something, this can be helpful. An alternative here to bring up is an instrument and a method that is gaining some traction in the literature. Maybe some of you are familiar with the screening scale for pedophilic interest 2, the revised version, or SSPI2. This is scored based on someone's history. So there's only 5 items. If they have boy victims, meaning males younger than 15, multiple child victims under age 15, a young child victim, meaning under age 12, extrafamilial child victim, and that's defined as beyond first cousin and younger than 15, getting back to that idea of a extrafamilial specifier with diagnosis. And then have you used child pornography? So, meaning depictions under age 18. The SSPI2 has shown some promise. You can kind of see here the psychometric properties. Depending on the cutoff score you use, the sensitivity and the specificity change in, the expected ways, as does the positive prediction and negative prediction value. And you see the percent who are ultimately diagnosed with pedophilia. And the reason, even though they call it the scale for pedophilic interest, is that given the stimuli, even the authors have started to think, well, maybe this is more of a scale of pedohebophilia. And if someone's used, I've not used this myself in clinical practice. If someone has, your comments in the chat would be welcome, to maybe a quick description of your experiences. Another approach, another technology for evaluating sexual deviance is visual reaction time. And probably the most common measure here, the ABLE. So view images of males of different sexual ages on a computer. We ask people to rate their sexual interest. And one of the variable that is really paid attention to is the time spent viewing, measure the time spent viewing. Its use is the use of a visual reaction time measure such as the ABLE is not as widespread, but it is used. The psychometrics are not well documented. The admissibility in court is not universal. And some of the algorithms aren't as well known. So it hasn't gained quite as much traction as some other techniques, but it is out there in the market and in the literature. Looking at a 2017 study comparing different groups, sex offenders against children, against non-offenders. You kind of see the table notes there. Take a look at this. I mean, these Ds are pretty good size effects. So there may be some promise here. I wish some of these things were a little more transparent and more easily to identify. But as you can see, the literature and the marketplace does provide us some ways for more directly measuring sexual deviance. Although, again, my experience with most practitioners is that they tend to rely more on clinical interviewing, which of course has its own shortcomings and benefits. I'd like to get into some about risk assessment models and methods. There's three methods I want to focus on here. The first is unstructured clinical judgment. And those people who work in the risk assessment field, whether it's sexual violence or other forms of violence, are probably familiar with this idea that these different methods are associated with different predictive effects and accuracy. Unstructured clinical judgment relies on a clinician's individual experience, subjective decisions, that clinician's combination of whatever risk factors they are entertaining and considering. Of course, being that it's idiosyncratic, it's affected by perceptions of frequency rather than actual probabilities and everything else that might influence perception. And by its very definition, or by its very nature, it's unresearched. We don't have a research study on every individual clinician. So an alternative that has been around for a few decades is actuarial risk assessment, right? These are formally developed instruments from empirically derived risk factors. So looking at the literature, what seems to be associated with the risk we are trying to assess, developing a structured algorithm for combining risk factors, and then those scores on these measures are compared to developmental samples and linked to outcomes. So therefore, the use of these scores are data-driven. We have some meta-analytic research that helps us compare these approaches. Grove et al. In 2000 published a meta-analysis that was very influential. You can see here, mechanical would be referring more akin to actuarial techniques. You see these where does clinical exceed mechanical, where are they equal, and where does mechanical exceed clinical? And across studies, that's what those numbers are. You can see here that if you're choosing a method, it's pretty clear that the mechanical approach would be better than the clinical approach. And then we have other 2006 meta-analysis that presented data in a similar fashion. Again, the same pattern where statistical methods exceed or outperform clinical measures. And then there's a more recent meta-analysis in 2025, or excuse me, a study in 2025 that examined clinical overrides of actuarial assessment. So this is when you take an actuarial assessment and then the clinician gives an opinion that varies from that based on whatever they're seeing in an evaluation. And you can kind of see here that the predictive effects, as indicated by area under the curve in a ROC model, that the predictive effects are diminished with the override, whether you're looking at the total sample or they had a subsample. So again, this really suggests that the actuarial methods are better. An example of the most I would assume to still be the most commonly used actuarial method is the static 99R. It's an actuarial risk assessment. As I mentioned, it relies on static and historical risk factors, hence the name, and it's scored from records. And there are normative comparisons available for varying groups of sexual offenders. You see the predictive effects there over a large number of studies and a large aggregate sample, 71,000. Here are the items. And you can, they're all scored as 0 or 1, with the exception of age of release, which is scored from -1 to 3 as you get, 1 to -3, apologize. As you get older, your score is lower, and that is a reflection of the age crime desistance curve. And then prior sexual offenses scored 0 to 3 based on the number of arrests and the number of convictions. The rest are scored 0 or 1. And we can take these scores that range from -3 to 12, although once you get to 10, you don't need to get any higher for looking at. You can kind of see here the risk estimates, the confidence interval around those estimates, and the relative risk relative to the median score of 2. And I think that this data, this presentation of data, can be very helpful in context where resources are limited. In my experience, using conducting evaluations for sexually violent predator commitment in Texas, where there's limited resources for the justice system to place someone in a commitment facility, thinking about not who is at risk and who is not, but who do we want to apply these expensive and invasive criminal justice management methods. The relative risk, it can be very helpful in communicating that to a decision maker or stakeholder. Now, again, the static 99R is based on static risk factors or historical risk factors. It's also important to consider dynamic risk factors. And a method, an actuarial measure that has gained some traction is the Stable 2007. It relies on, as I mentioned, dynamic risk factors scored based on records and interview. But the value that it has, and I'm grateful that the authors and others have put this together, is that it can be combined with the static 99R for an integrated risk assessment. So here are the 13 Stable 2007. One item there I'll point out, number 3, emotional identification with children, is not something that we would score for someone whose offenses are only limited to adults. But and it refers to this, I don't know, kind of briefly, kind of someone whose emotional needs are congruent with that of children. But you can see here how these other dynamic risk factors, it's not hard to see how they might relate to reoffending. And I use both in my work and what I present to decision makers, like, for example, the prison system in Texas would, and it might wind up going before a judge and jury, is the integrated score. And you can see here how you have this matrix of scores, matrix of risk levels, and they range from 1 to 4B. And you have the stable scores across the top, the static scores down the side, and you can kind of see where someone who is in the moderate range of stable scores and in the moderate range of static 99 scores would be a 3. You kind of see the yellow there. Higher in one, lower in the other is associated with being in the moderate range. You can kind of see how this would work. And we have these estimates and so for the various risk categories, with the average category being a reference group for relative risk. Again, I find this really helpful when communicating to decision makers about, if someone needs to be the most invasive, restrictive, and resource intensive management techniques or methods. Now, a third method that I haven't gotten to yet, but I will now, is the structured professional judgment approach. These are formally developed instruments using a fixed set of risk factors that are defined in a common way and with defined scoring or coding procedures. You don't really use scores with SPJ instruments, not necessarily linked to an actuarial outcome, like in the case of other actuarial methods like the static or the stable. More often using categorical descriptions, low, moderate, or high risk. And the SPJ instruments seek to optimize the application of nomothetic data, like the data based on groups, in an idiographic context. So thinking about, okay, I want to apply data based on groups, but I also have to consider this individual. And they do show positive effects. You kind of see here, let's just stick with the sexual violence and looking at this 2009 meta-analysis. You kind of see here that the SPJ instruments have positive effects. The empirical actuarial instruments seem to be stronger, but there are contexts where actuarial instruments cannot be used. For example, I once had the occasion to evaluate a woman who had been for sexually violent predator commitment, and the static 99R, which was what I was using at the time, really, and other instruments have not been normed for use with women. This SPJ was a better option for that context. And an example of this would be the risk for sexual violent protocol. It's in its second version, the RSVP, published in 22. See the items there, and they are scored as present, partially present, or absent. And across, you can see there's overlap in content with some of the other instruments. So it's not surprising that this has been proven helpful. But you can kind of see here some predictive effects with in a recent study from 2025, and the AUCs for the RSVP, and then the SVR20, just for comparison, is a very similar instrument. Same group published it. They're, I don't know, first cousins or even closer, and with similar predictive effects using the AUC estimates. So the SPJ effects are good, and this is a good consideration for those working in this field if your circumstances require it. Now, the last thing we've been talking about risk factors, and and I don't know, I kind of sometimes will say we've been talking about all the bad stuff. Well, this there's a lot of bad stuff in what we're dealing with in this field, but there is a other way of thinking about this, or an additional way. Some authors and scholars have started to talk about more about looking at protective factors as well as risk factors. An instrument that seems to come up more than others. Yeah, I'm not even sure if there are too many others. The SAPROF, the Structured Assessment of Protective Factors Against Sexual Offending. Kind of see here that the content area in some places overlaps a little bit, like, for example, adaptive sexuality, but looks at some other things that would be protective, resilience, pro-social connections, and risk management. And so here's a 2023 study based on 2010 offenders in New Zealand. It was a retrospective archival study. And you see the AUCs for the SAPROF were really good, comparable to static 99R in the same sample. So I think that I think that there's probably a future with considering protective factors as well. I mean, probably opinions will vary on whether the literature is there but with this growing body, I could see eventually us getting to a place where we can combine protective factors with risk factors, static and dynamic, to get a better picture, even using actuarial data. So let me close out and open up for questions and discussions. I realize I've been going very fast. I have a tendency to do that, and I apologize to everyone in advance. But kind of by way of summary, there are evaluating risk involves consideration of paraphilic disorders and other disorders, especially in criminal justice context. The actuarial and SPJ models seem to have the strongest empirical support, and that, as we pointed out, that sexual deviance, any social orientation are constructs most associated with recidivism, and we have to consider static and dynamic risk factors, and assessing protective factors shows promise as an additional component of assessment. And I should, by way of explanation, being a former Air Force officer, we were trained to, when we deliver presentations, we tell people what we're going to talk about, then we talk about it, and then we tell them what we talked about. And that's what I've just done. So let me open up the floor with Anthony's help for questions and comments. And I thank you all for your attention so far, and hopefully we can have some productive exchange of ideas now too.
All right. Yes. Thank you so much, Jorge, for that overview there. We do have a number of questions here already. Feel free to enter those into the Q&A box as they come up as well. We have a number that we can go through right now. In the meantime, we will be preparing in the chat for the CEU survey shortly. That will be just a little bit while longer. Somebody asked a general question about when does, and in their words, an odd sexual activity become a disorder. Their example is there are people who join furry groups, pup groups, and dress in outfits associated with the focus of the group, but appear to all be consenting adults and function otherwise without difficulties. So I guess the question here is, when does something that we might consider unusual become a clinical disorder?
I think that's a great question, and I think that applies to a lot of these things. And we could certainly, and I'm going to get to answering the question, but just let me add to the concept that things like transvestic fetishism. I mean, where does that become a disorder? Some have argued doesn't even belong there, and made good arguments about that. For me, and I invite others to chime in the chat as well, I think, like any other disorder, a behavior becomes a mental disorder, something that we diagnose when it starts to impair. So I would say, for example, if someone is living, you mentioned like furry, if someone is doing that with consenting adults and circumstances where everyone is consenting and okay, I wouldn't necessarily think of that as disorder. If on the other hand, if doing that causes the person distress, but yet they feel some compulsion to do that, that would start venturing into the area of a disorder. If they're doing it in such a way that causes them problems, so if you have I don't know if you work in Wall Street, that's maybe an extreme example, but dress that way to work because you feel so strongly about it, that could become a problem. I don't know if it's the interest itself or how you're managing that, but that to me is how I would define anything as a disorder. When it causes problems, when it causes you impairment, when it undermines other relationships and other satisfying, meaningful things in your life, then I would start to question, whether or not this is healthy and ultimately is this a disorder that needs to be addressed clinically. I don't know if anyone else has any thoughts, please share them, including you, Anthony.
Thank you for that. Yes. Somebody asked regarding your clinical experience. I know you've done a number of these evaluations in Texas in particular. From your experience, are there any particular measures or particular types of information about a risk assessment that courts seem to be most interested in?
One thing that I think it's important, and I mean, I guess this is true in any forensic assessment, but here, because we're dealing with often people who have engaged in some behaviors that are really difficult to countenance, like, for example, sexually abusing a child or multiple children, that you can explain how you got to your opinion. For example, your risk opinion, if you can describe what are the risk factors that are considered in these instruments, and what did you do? For example, static and risk factors. And as I think one of the things that is important to understand in this work is that the general public, right, tends to think of the recidivism rate among sexual offenders to be very high. Survey research looking, surveying public eye, how likely do you think this person is to reoffend? Those estimates are in the mid 70%, and different people have done the same study, and they kind of generally converge on the same kind of conclusion that it's a lot higher than what it seems to be. Even if we think of that 11.5% that I suggested before, or maybe 13% that's in other studies, as an underestimate because so many things go undetected and the criminal justice system handles things in other ways, it's still probably not 75%. So you have to communicate things that whether it's explicitly or implicitly address that. I mean, that the judge and the other decision makers, like a jury in the case of a sexually violent predator commitment hearing, which sometimes can be in front of a jury, that you can explain why this person, that this person is low risk when the conventional wisdom, even if it's not necessarily wise, is that it would be higher. I had the experience of testifying about sexual violence risk in an immigration proceeding, and what's unique about, I mean, it's an own set of procedures in the justice system. But in this particular instance, the judge was essentially doing the work of the prosecutor or the government attorney, rather, in wanting to know, well, what makes someone average? How many offenses? And of course, it doesn't exactly work that way because it's based on a combination of scores that get you to the actuarial score, for example, on the static 19R. And I had to be able to explain this is what a 2 means. And it doesn't mean it's one homogeneous group, but it is a group of people that, based on all this, fall into this median score. So I don't know, I think that's helpful. And again, it's counterintuitive to think of, for most people, to think of a sexual offender as low risk. So being able to address that in some fashion, whether it's explicitly or through how you document your evaluation.
With regard to descriptions of risk, say like average, above average, below average, somebody asked, is that relative to other people who have offended? Is it relative to the general population, some other group? What do we mean by average risk, below average risk?
I think in this case, so for example, let me see, I can Let me, if it's okay, you want me to, can I go back in some slides?
Yeah, certainly. Mhm.
Oh, sorry, wrong direction. So in this case, so let's look at the static 19R. This is the best example, right? The When we think about average, is this median score of 2, okay? So when we think of someone as below average, it is relative to that score of 2, and those offenders in the development samples that scored a 2. And the same thing for the same thing here. These scores are relative to the other offenders that are here in the can you guys maybe I hope can they see my oh, here, can you see my pointer? We have 1s and 2s here, we have 4s and 4Bs. I don't know why they don't use 5. Maybe there's a good reason. Maybe there's a 5 is reserved for something coming. But that's what it's referring to. It's referring to their scores on these actuarial methods.
Thank you for that. Incidentally, I recall discussion about why there was not a category 5.
Oh, please tell me.
That these categories are based on risk, I believe, in more broader medical literature. And category 5 is essentially a guarantee 100% chance of recurrence. And as we know, because of a number of different factors, we wouldn't say that somebody is absolutely guaranteed to reoffend.
Well, that's interesting, and not to mention sensible, the idea of let's not confuse people that might use that particular label, for some other, or for another purpose. Like hurricanes, for example.
Exactly. Yeah.
Thank you.
Yeah. So somebody asked how much insight into behavior affects recidivism risk for people that have sexually offended. They said sometimes we see offenders with a lot of guilt for their behavior, but there are also some with no insight, also some with cognitive deficits that might impact their insight. So how much does insight into behavior seem to affect risk?
That's a great question. And I don't know that our literature provides us a great answer. So in those earlier meta-analyses that I cited before, for example, the Hansen-Morton-Bergen study that from 2005, they found, and this isn't exactly insight, but it's sort of adjacent to that, is that denial of offense was not associated with recidivism. And I think that the literature on denial has sort of been that way, but I think how we define denial is not consistent and maybe well operationalized yet. If someone knows of studies, please share them in the chat. But, one thing, and any of us who've worked with offenders, have had the experience of, there may be unequivocal evidence in records and investigation records that someone did something. They say, well, I didn't do it. I've heard, in my evaluations, the victim's mother said that I did this because I wouldn't have a relationship with her or because I ended my relationship. Okay, I mean, that is denial, certainly. But then there is the denial of, well, I did this. For example, I sexually abused this 10-year-old, but that's not really something bad. And that form of denial, and there is a literature that tells us that the presence of these cognitive distortions, which may get more to the question of insight and things like that, is associated with more recidivism, but it's especially cognitive distortions related to their own victims. I recall a study, although I couldn't cite a chapter and verse on it right now, where they found that offenders, especially people who had sexually abused children who had low empathy could show empathy for kids who were harmed in many ways, other ways, non-sexual, even kids that were harmed in sexual ways by other people, but not the same empathy for their own kids, for the kids they abused, that they offended against. And similarly, again, back to the idea of the presence of the more cognitive distortions, like this is, I needed to do this so they could learn about sex, those sorts of things, which may seem very appalling when you hear someone talk about it. those, not surprising, those, the presence of those is this, more of those is associated with a higher risk.
Thank you for that. Some
Sure.
people have followed up on the discussion about high risk, low risk communication with the follow up of how do you translate and communicate risk when you use a structured professional judgment tool that doesn't say have a specific score or corresponding risk label the same way that an actuarial measure would.
Well, again, my experience with SPJs is much less than my experience with the actuarial instruments, but I still think I can offer something for consideration. That is, I think you use the category, low, medium, high, below average, average. Various instruments have different ways of. I tend to use the language that the instrument developers used, although we could debate whether or not that's necessary. But I would say that there you would have to qualitatively, that is through your description of your conclusions, talk about, okay, I think the risk is moderate because I'm seeing these risk factors in my structured assessment, but I'm also not seeing these others, and maybe here's some things that seem protective. And that's how I got to my conclusion. I think that the very nature of structured professional judgment is that it involves you describing how you made your judgment and what was there. And I think between that and a combination of what the instrument you used is, say, let's say you're using the RSVP and where its value lies in this, this circumscribed but list of risk group of risk factors, and how some are high, some are medium, some are low, and you kind of describe all that and everything and the idiographic data that pertains to a particular offender. So and you can, and that's how you would communicate it to a judge, a jury, maybe a criminal justice decision maker, or maybe a community supervision officer, whatever the case may be.
Wonderful. Thank you for that. A couple of people have asked questions related to how is sexual risk assessment affected when the person is in custody. Some people have asked about critical differences of assessing sexual risk for somebody in custody while they are in custody, challenges of assessing somebody's sexual risk while they're incarcerated, not in the community. Any thoughts on any of these?
I think that's a great point to ask that question. I find my work has been primarily with people who have been in custody, and not only were they in custody, but they have been in custody a very long time. In Texas, as in the other states that have sexually violent predator commitment, these people have been in prison and they had multiple sexual offenses, not necessarily for that particular incarceration, but maybe they have been incarcerated for a sex offense before, and then were incarcerated after having reoffended a second or third or whatever number of times, and then had been in prison for a long time. And if you think of state of Texas being tough in crime and punishment and things like that, these people have been in prison for sometimes decades. So it is difficult. The actuarial risk, the static risk factors don't really change, but where it gets challenging is where some of these dynamic risk factors, for example, using sex as coping, which is one of the Stable 2007 items. Well, if you're in prison, you could use sex as coping. I mean, people have sex in prison, but they may not be willing to talk about it. But you may have to rely on other indicators, like, for example, maybe using masturbation as coping or something like that. People they're usually not in any kind of relationship, which may be which would increase risk on the Stable 2007, like they're not in a current relationship. It gets hard to identify things like emotional congruence when they haven't been around kids for 20 years. So it's really difficult. And but I think that you have to, it's one of these things where I think you just have to acknowledge the limitations of what you're doing, that there's no way around that reality that people have been in prison. We do know that deviant, what we think of as deviant sexual interest, like what you would use, what would become diagnostic in the DSM, those tend to have a persisting course. Now, the behaviors that form a disorder, like for example, acting on those sexual interests, may not persist as sexual desire decreases over the lifespan, especially in old age, and sexual functioning can change and things like that. That the interest tends to persist. So that's a consideration as well that I have documented in my own reports. For example, saying that, well, somebody hasn't been around kids for a long time, but we do know these things tend to persist. The interest does. I wish I had a better answer for that. If you figure it out, publish it or do something and you'll be a millionaire. So
I want to alert attendees that the APA CEU survey is in the chat box there. Make sure you click bookmark, copy that link before the webinar closes if you'd like APA CEU credits. It's right in the chat box there. Somebody asked regarding when you discussed pedophilic disorder diagnosis and the limited to incest qualifier there. Does that refer to types of victims who have been abused, yes, or specifically attraction?
Well, it's both. I mean, in the sense of the DSM doesn't make a distinction in terms of that. But we do know that extra-familial offending is associated with higher risk and therefore worse outcomes. Right? And if you give some thought to it, maybe I'm sure I'm not the only one that sees this. Maybe everybody, all 590. All right, the number is dropping. Anyway, 590 something people that, if you're going through the trouble, one thing is like, oh, I offend against my niece in Thanksgiving or my, when they're in the house, or for a family gathering. Another thing, you're going out of your way to the playground to find the victim and put yourself in that risk and going through that trouble. It kind of makes sense that would represent a greater effort to do this. To me, it seems like that. So I kind of see the value and the distinction. But that's typically what to think about, who you're interested in or who you engaged in the behavior with.
Somebody noted they're in a jurisdiction where a direct interview with the person that you're evaluating risk for is voluntary for them, and they, of course, could refuse. Their question is, what would you say are some limitations of using tools like the Stable and all that without the ability to actually interview the person?
I think that you wind up in a lot of jurisdictions, you wind up being unable to use them. And I'll say my experience in Texas was that the files did not contain a lot of information about like other people interviewing the offender and getting some of this information. And part of the thing for me, in my point, where these are done in accordance with the law, is before they're in any kind of sex offender treatment, where they might disclose some of these things. And if you gain access to the records, you might get some information about some of the dynamic risk factors. So I had, and I will add that in Texas, we were under the law required to assess psychopathy. And I think everyone just used the PCLR. And without an interview, the records were, even though the PCLR and probably the Stable could be scored from records if you have thorough and detailed records. In Texas, they don't talk to the offenders in prison. I used to joke, like, I guess in the places where they develop some of these instruments, they talk a lot to the offenders. In Texas, they do not. So we were left with not having that information, not being able to get any of this from the offender, and just having to rely on, for example, static, historical risk factor like the static 99R, and then just explaining I couldn't do the other ones. It's limited to just this.
So it reminds me a little bit of some of the, original work where you and I first came in contact all that time ago when we talked about ethnic status, ethnicity, yes, versus actually immigration status and the complications of immigration status, and having limited records and limited information was hindering assessment much more so than purely looking at ethnicity from just a generalized, broader lens like that.
Yeah, in the absence of records, for example, someone that lives, maybe someone who's an adult but spent much of their, even including adult life in another country, we may not have access to those records and then are just bound to rely on self-report, which is really not something you're supposed to do with the static 99R, for example. With maybe the exception of the relationship, ever live with a partner for 2 years item, that one usually don't get out of records, although maybe you can. And even when they're in the records, they're usually self-report, like somebody told somebody else that they lived with somebody for 5 years or whatever. So, yeah.
As we wrap up here at the top of the hour, just one final question here. Somebody asked about your advice, particularly for evaluating individuals that have intellectual disabilities in this context.
Wow, that's a hard one. I've only had to do that a few times. Unfortunately, our instruments do not have maybe separate developmental samples based on intellectual functioning, or what might be a developmental disability, other forms of developmental disability. I think that but also I would consider that there are probably people with limited intellectual functioning or other developmental disabilities in the developmental samples themselves. I mean, that's in the norms. So I would suggest that maybe that you would just have to place caveats on your opinions that, that these have to be interpreted with caution. And you would, of course, take that caution as you're doing the evaluation. There are some, if you're in a situation where you might have to use something like the PCLR, like a psychopathy measure, there are some researchers who have published data like, in a sample of developmentally disabled offenders or people, here's, PCLR scores for the facets, for the factors, for the total, and you could maybe consider those in addition to the regular normative sample to kind of triangulate in on an opinion about someone. But I would feel best if I was using a lot of caveats in that, this is not the standard person for whom these things are often developed. There is a literature on developmentally disabled offenders, and a lot of it has more to do with treatment and how to manage and things like that. Maybe there's some stuff on some of the risk assessment measures. I'm not familiar with it. I didn't have to deal with that often. So there you go. Sorry, I don't have a better answer to that. It's a great question.
Dr. Varela, Jorge, thank you so much for all the work you've done in this area and sharing all this information with us. It's great to have you here at UNM, and we're thankful for you joining the series and sharing your expertise with us today.
Well, first, of course, you're welcome, and it's an honor to be asked, and it's an honor that so many of our colleagues were willing to listen.
Mm-hmm. Yes, and that does wrap up this week's Law and Mental Health series. As a reminder, we'll be away the next 2 weeks for the American Psychology Law Society conference. We will return on March 24th with Dr. James Fairfax Colombo discussing issues with the sequential intercept model. We hope to see you then for another great discussion of issues in behavioral health and the law. And until next time, take care.
All right. Bye, everybody.
All right. See you in a bit.